Good afternoon. Can you believe the year is almost, we're halfway into this year, so. Fine. And today, our speaker is from Reid Gastroenterology. I did get that correct. So, and Amanda Gibson, who I've coerced into doing this. We've been on a tour together, so she's done Let's Talk Together and Medical Money, and she'll be with me again on Thursday in Connersville. So without further ado, we're going to introduce Amanda Gibson. And Amanda, and of course, you started by telling us about how you came to Reid.
Hello, again, my name's Amanda. I became a nurse practitioner in 2018. I was a bedside nurse for 10 years prior to that, having cardiac step-down floor, ICU, and emergency room experience. I came to Reid, actually I did a lot of my clinical experience with a family nurse practitioner, and I really enjoyed the atmosphere, the people that I also worked with in that office, so I was able to find a job within Reid. And then July of 2019, I actually moved on and I found a job within gastroenterology and hepatology, and I wouldn't change it for the world. I absolutely love it. I've been there since. Started off as a dual role as a practice manager and a nurse practitioner, and then went until they found a nurse, a manager for the office, and I went full-time nurse practitioner. So, and I like it this way. I've been with Reid Gastroenterology, like I said, since July of 2019. I collaborate with Dr. named Raza, who is the physician in our office. I also work with another nurse practitioner, Rachel Wilmot. So there is 3 of us in the office right now for Reid Gastroenterology. All right, we're gonna start our, yeah, there they are. Okay. All right, so on our agenda today, we're gonna talk about colorectal cancer, epidemiology, risk factors, symptoms, and the testing that we have for colorectal cancer. Can everyone hear me okay?
Maybe a little bit louder.
Okay. Usually I'm pretty loud. So we'll talk about the incidence of colorectal cancer. Globally, colorectal cancer is the 3rd most common diagnosed cancer in males and the 2nd in females. The mortality is higher in males than in females. There's 154,000 new cases of large bowel cancer diagnosed annually. So 107 is colon cancer. So when we talk about colorectal cancer, that's the large bowel plus rectal. So 107 cases for colon cancer and then 47,000 cases of rectal cancer. Approximately 53,000 people die of colorectal cancer in a year in the US. Colorectal cancer mortality is approximately 33% higher in males than in females, so great difference. And then 65% of patients treated for colorectal cancer between 2011 and 2017 had a 5-year survival rate. So we talk about risk factors within colorectal cancer. So there are risk factors that can be changed and there are risk factors that cannot be changed. So risk factors that cannot be changed is your age, your racial and ethnic background, your sex, and there's other things regarding personal history of colorectal polyps or colorectal cancer, inflammatory bowel disease, history of abdominal radiation, family history of colorectal cancer or polyps. There are also inherited syndromes like Lynch syndrome and polyposis. And There are lots of risk factors that give us increased risk of colorectal cancer that can be changed. So obesity is a risk factor. Type 2 diabetes is a risk factor. Diet, people that eat high in red meat and processed meats, that also has a small risk of increasing your risk of colorectal cancer. There's cooking meats at a high temperature. This was something when I was digging into this to prepare, this was kind of fascinating to me. So cooking meats at high, so frying, broiling, grilling, those type of things. Smoking and alcohol use. I'm gonna go. You go back. So I was just, right here. I was just gonna go a little more in depth. So, among the highest incidence and mortality rates of colorectal cancer is Black Americans, Native Americans, and Alaskan Natives. And then when we talk about the risk factors that you can change. So one of the studies, so there was 14 studies that looked at diabetics versus non-diabetics and how this increases your colorectal cancer incidence. So it's showing that 38% higher risk of colorectal cancer with patients who are diabetic versus non-diabetic. And you also have an increase 20% higher in rectal cancer. High temperatures with cooking food, we're not sure, but what they've looked at is the production of it's hydrocarbons and other carcinogens produced from proteins in the charring process that could increase your risk. I mean, these are low, but it's still a risk factor that can be changed that increases your risk. Tobacco smoking has a high risk of colorectal cancer and incidence. It also has an increased risk of adenoma. So these are the type of polyps that can become cancerous. You also have a higher risk of dying from colorectal cancer because treatment, while you're smoking during treatment, also increases that risk. Alcohol use. This also is a higher incident rate with the colorectal cancer. They're thinking that it may be related to the interference of folate absorption from the alcohol use and the decreased folate intake that you have. Also, consuming alcohol, it also affects other malignancies and treatment as well. There is a study, which is a small incident risk of 1.16% of right-sided colon cancer for people who have a history of cholecystectomy, having your gallbladder removed. There has been reports, there's been a large study of patients followed up from 33 years after surgery, and there is that slight increased risk of that right-sided colon cancer that I found, but they're not sure 100% of why, but it does show from the studies that they have done on the patients. They have something they're looking at if it's the bile absorption, since you don't have your gallbladder anymore, if that has something to do, but it's a very small incident rate. So symptoms can vary. So a lot of times change in bowel habits. If you went from normal bowel consistency, soft form, or now you're having diarrhea or constipation, those are things that we're looking at if you need a colonoscopy, or for concern for colorectal cancer. Also, rectal bleeding. If there's blood in your stool, blood mixed in the toilet or when wiping. There's continuous abdominal pains that we have. You've had imaging done, CTs done, and we're still not sure of what this abdominal pain is caused from. If you're not evacuating your bowels fully, that's also something that needs to be discussed. If a colonoscopy needs to be done to be further evaluated. Weight loss, that's something that needs to be discussed, and if a colonoscopy needs to be done. Weakness, tiredness, unintentional weight loss. There's iron deficiency anemia that you look at. If you're having low iron stores, low hemoglobin, that also needs to be done to evaluate if there's any bleeding, if the bleeding is coming from a mass or a polyp, or may have diverticula that could be bleeding. But that could be a whole nother subject. So in regards to colorectal screening, so there's different modalities of how we can screen for colorectal cancer. So colonoscopy is the gold standard. So people think, okay, I get a colonoscopy, don't have to do it for another 10 years. So there are risk factors. So colorectal cancer screening starts at age 45. If you have family history of risk factors of they've had colon cancer, they've had precancerous polyps, you have those polyposis, these other inherited diseases, then, and this also depends on your insurance, that sometimes the screening can start before the age of 45. Sometimes, we recommend at the age of 40. Inflammatory bowel disease, you're going to be getting colonoscopies way before the age of 45, because that's no longer a screening, that's more of a diagnostic. What we have here, this is just showing screening colonoscopies every 10 years. That's if it's a clean, you don't have any polyps, nothing that's abnormal. So you get one every 10 years. Also depends on the prep. So all these things are decided. How well your bowel prep is, how many polyps you have, if it was completed, if not, and if there's any concerns going forward. So usually after you get your colonoscopy done and the pathology is resulted, that's when we will tell you, when your repeat colonoscopy is. We have also a FIT test. So this is a stool test, and this is done every year. I don't see this done very often, but this is showing the sensitivity of it and how well it's working. So colonoscopy, it's showing the sensitivity for colorectal cancer 95. The biggest, and then we see FOBT, fecal occult blood test, that's at 70%. Then there's the FIT DNA test, and then so that's more like if people have heard about the Cologuard. The Cologuard is very popular. That is a test that's done every 3 years. It is not the gold standard, but it seems we're able to get people to be screened more often because people are very nervous about a screening colonoscopy. So screening colonoscopies age 45 to 75. So, but I might be getting further along. So the Cologuard, which I see a lot of patients getting, is a stool test that is sent off. And what it looks at blood in your stool, and it also looks at DNA shedding. So every time you have a bowel movement, and if you have abnormal or polyp, you're shedding that DNA from that polyp. So the thing is this comes back as either negative or positive. You don't know if it's positive if you have blood in your stool or if it's the DNA shedding. So then what will happen is a lot of times family practice providers are ordering these, and then if it comes back positive, now you have to go on to a colonoscopy, okay? Now it goes from diagnostic scope instead of a screening scope, because your screening is your Cologuard. So for the Cologuard, the sensitivity that we have there is 92.3. So every Cologuard, it does have a high, and if that's one way we can get people to start the screening process, then that's what works. But the gold standard is a colonoscopy. We find that we have hard time to get people to do the colonoscopy because of the prep. So the prep is the big issue, right? Until I figure out a way, I'm still working on it. But we have many options of different preps. So that's one thing. That's the biggest fear every patient that I see in the office is I don't want to go through the prep. But I will tell you that the biggest thing and why our sensitivity for the colorectal cancer in regards to the colonoscopy, it's not that the colonoscopy does not find these polyps, it's because we have poor preps. So what's happening is because we have poor preps from either maybe patients have constipation, the prep that they're taking is not enough for them. We're still having a lot of stool on the right side of our colon. So that's not allowing us or the physician who's doing the colonoscopy to be able to really visualize that right side. Okay, so you can have polyps on the right, you can have polyps throughout. So then those patients, depending on how bad the prep is, either have to come back the next day doing more prep, or they may have a sooner recall. Recall meaning coming back to do another repeat colonoscopy in a year, 6 months, 3 years. So it's very important for a colonoscopy. If you have a history or a problem with constipation, I tell my patients, let's get your bowels regulated before we start this prepping, because it will really help with the preparation. And I tell people, the preparation is very important. You know, I know it's not fun, but it's very important to have a good visualization throughout your entire colon, because if you have a poor visualization, a polyp or mass could be missed because of the stool throughout your colon. Now, and like I said, the Cologuard, that I've seen lots of, so it's really not recommended after 65. I see a lot of patients that get it done and they've already had colonoscopies in the past and they have a history of polyps. If you have a personal history of polyps, if you have a family history of colorectal cancer, if you have a family history of precancerous polyps from your mother, your father, a Cologuard is not something you want to do, okay? You need a colonoscopy. Also, if you have a change in bowel habits, diarrhea, constipation, or maybe a change in your stool caliber, pencil-like or looking different, a Cologuard is not what you want, okay? We need a colonoscopy so we can visualize the whole colon to make sure mass or polyp, precancerous polyp is not being missed. Another thing is a fit test. I don't see this used very often. Usually primary care will use it. That's every year. That's considered a screening modality for some insurance. That looks at blood, but this usually will detect blood in the lower GI tract. So it's blood that we cannot see to our eye. So it can be seen through microscope testing. The FOBT is a fecal occult blood testing. So a lot of times this is used outpatient primary care office, but usually it needs to have 3 stool samples to look at all of them to tell us if it's positive or negative. A lot of times this is used in the hospital. If you go in and you're having some rectal bleeding or black stool, they'll do this as one of the things they'll send off. If you ever have a rectal exam, this should not be used as a screening modality because that can cause microabrasions and bleeding that can make your FOBT positive. So that should never be used. But the FOBT is every year. Again, that should have 3 stool samples prior to then figuring out, if you have 1 that's positive, 2 that's negative. And also we got to remember, if you have a history of hemorrhoids, that can also make a difference regarding these fecal occult tests. Because if you have hemorrhoids and they're bleeding, it's going to come back positive. And that's the same way, it could be with the Cologuard, but again, they look at a certain amount of blood with the DNA shedding. Sigmoidoscopy is a colon, it's a scope. You still have to prep for it, but it only goes to the sigmoid. That is not a screening modality. A screening colonoscopy needs to be a full colonoscopy. After the age of 75, unless you already have a history of polyps, and screening modalities have to continue, but if you've had colonoscopies in the past and they've been normal, there's no polyps, then we really don't recommend a colonoscopy after the age of 75. A lot of people do get them depending on if something else is going on. If they have a history of polyps, family history of colorectal, they'll continue to do that. Or if there's some bleeding going on, if colonoscopy needs to be done. But that's a discussion between the patient and their provider. There are risks regarding these procedures. So you have to be willing to know those risks, and then we have to outweigh risk versus benefits of the test. So I've discussed, screening colonoscopy start at age 45 unless you have family history of colorectal cancer, advanced precancerous polyps, or the family inherited like polyposis. So then, and again, it all depends on your insurance. We'll start the screening process earlier. Cologuard is screening colonoscopy 45 to 75, Cologuard. But again, it's not really recommended for anyone that has family history. Colorectal cancer, polyps. If you have a personal history of polyps, you do not do the Cologuard. After you've been diagnosed and you have found that you have polyps, you will continue with the colonoscopy. We've discussed the FOBT and the FIT test. Just jumping ahead. So the screening colonoscopy. So the benefits, it looks at your entire colon. So it goes all the way from the anus all the way up to the end of the small bowel, which is called the terminal ileum. So we're able to look throughout the entire colon. If you have a polyp, that can be removed at that time. Okay, any polyps that you have are removed and sent to pathology. Completed every 10 years if normal. So it all depends on what that initial screening is. It can help diagnose other diseases. So if you're coming for a colonoscopy because of change in bowel habits and you're concerned for IBD is inflammatory bowel disease like Crohn's disease or ulcerative colitis, biopsies is what helps with diagnosis. Diverticulosis, they can see a lot of people have this as pockets in your colon. There's other things that can be also diagnosed during that time, depending on what your symptoms are and what we're looking for on that colonoscopy, if we need to do random biopsies as well. But that's something that, the provider and the physician, Dr. Raza, doing the colonoscopy, that we collaborate together. This is what I'm looking for. This is what I need biopsies so we can roll this out. Cons. Well, first one is the bowel prep. Again, sedation. So I don't know, some people would say that's not a con, but sedation, you are in twilight, you're kept comfortable, you're breathing on your own, but you are sedated. So the age, as we get older, we have increased risk, right? Sedation is like number one. Anesthesia is the biggest risk factor as we get older. There's also risk of bleeding, especially if a polyp was removed. You could have ongoing bleeding for a short period of time afterwards. There's infection, bowel perforations, but this is very, very minimal risk. And this is something that is discussed. I have a lot of patients that need a colorectal screening, a colonoscopy, but they want to come to the office and talk about these risks and, You know, do you have diverticulosis? Is it severe? Is this going to cause an increased risk of perforation? So all these things can be discussed if there is some concern regarding the colorectal, the colonoscopy. So in regards to the bowel prep, so the bowel prep, yes. So we have different preps to accommodate people. So, you know, everyone says, well, give me the pills. I want the pills. So we have the pills. We do. A lot of times people get cramping, and you know, if you take these pills and what it's supposed to do, you know, usually the cramping will be there. Some people have a hard time keeping the medication down, the pills. You know, I tell patients, you know, I can provide some Zofran to help with the nausea while you're going through this process. But a lot of times we use Docalax and we use a Miralax prep. So with Gatorade, and it has worked very well for people. There's also Docalax and mag citrate, but this is not recommended for people with chronic kidney disease. So most of the times we are working with Docalax and the Miralax prep, but there are other ones, you know, everyone knows the big jug, right? Yeah. We don't use that one too often unless we have a patient that has been through many colonoscopies without a good prep. Then the jug comes. But most of the time, as long as we can regulate the bowels prior to the prep and do the Docalax, Miralax, it works well. We talked about, so Cologuard, it's stool-based, could be done at home. There's no risk, you know, to the colon because you're not getting a colonoscopy. There's no bowel prep. But again, it does have false positives, and you know, once you get a positive back, and we don't know if it's blood, we don't know if it's DNA shedding, so you know, these patients are usually freaking out until they actually get their colonoscopy done, and you know, to say, okay, you know, there was no polyps, there's no cancer. The Cologuard is completed every 3 years, but again, if you have a Cologuard that is done and it's positive, the next step, it's not to repeat the test, it is colonoscopy is what is next. This is what I talked about, fecal occult blood test. Again, this is stool-based. Usually it needs to have 3 stool tests completed. This will show if you have any occult bleeding, meaning that you can't see it by your eyes, but we don't know because it looks for blood upper and lower GI. So if it comes back positive, we don't know if there's bleeding going on in the upper GI tract or the lower, or maybe the small bowel. So we just know positive, negative. If it's positive, then we go and the colonoscopy is next. And a lot of times people that get these FOBTs or these FIT tests, these stool related tests, there are things that need to be done prior. So you shouldn't be on NSAIDs. That can affect the result of these tests. And a lot of people don't know that. Vitamin C, eating red meats, all these things can affect the results of those tests as well. If you have hemorrhoids, again, that can also affect the test to be positive. And this is FIT test. This is the other fecal stool test that I talked about. And this is what, again, if it's positive, then we go on to the colonoscopy. This one looks for any lower GI bleeding.
That's it.
I got through that quick. Are there any questions? I like questions.
How, you said that the one required is 3, the bowels. Okay, is that hold what period of time? It's not 3 in one day, or how many days, or?
Just 3 consecutive.
3 consecutive, okay. It can differ that much?
And again, I talk to a lot of patients when they've done this, and I think there's even an inpatient, because I round inpatient as well, is we don't realize the things, you know, the medications, even food, vitamins come into effect and can cause a false positive from these results.
You mentioned, I was baffled by the grilling.
Yeah.
Meat is,
I was too.
'cause
A very,
I mean, wow.
yeah. It's a very low incidence rate, but it's still there, a factor that we can change.
But is it just grilling or over grilling?
So like charring, yeah.
Okay.
Now, would that even, because some people will char their vegetables, like bell peppers and things like that now, and it's not just limited to, or is this just limited to meat?
So this risk factor that was discussed, and I looked in, it was in regards to meat.
This may be, you made me answer a bit early on, but I've heard of people who've had colonics. Is that what it is?
Oh, like the bowel prep prior, like,
It's not bowel prep, they're just doing it to.
The cleanness?
oh, yeah, like a enema.
So, I mean, if somebody's not clear when they come to the hospital, is that an option?
That's not something we provide, but I know what you're talking about. I see that. Yeah. Yeah. So generally, depending on the circumstance, we have a lot of patients with poor preps. I mean, patients will tell me, I didn't even start using the bathroom until that morning of, after they've already taken all of their stuff. To me, that tells me you probably do have a problem with constipation. And that's why it's very important, even because a lot of times the primary care providers send these orders through to our office for colorectal screening. So you never, that doesn't, and it's called what's open access. So you may, we send it on that you need a screening. So you may not see someone in the GI office ahead of time, myself or Rachel, because unless you have some cardiac risk factors or diabetic or sleep apnea, so there are risk factors that you have to be seen in the office first. But if you go straight through the screening colonoscopy, that's something that I don't think is being discussed in the primary care, like other than, hey, I'm going to send you through for a screening of colorectal cancer. But we also got to, it's not really being discussed. Well, do you have constipation? Do we need to do something before this? Here's your bowel prep. So, that also has effect. And because we have more and more, we have fair or poor preps, or even incomplete colonoscopies because the preps are not working as well because the patients are having constipation. I mean, sometimes it could be because a patient isn't taking the medication like they're supposed to, or they're eating still that day of. So because prior to your colonoscopy, you're on clear liquids the day before, okay? Our office does provide a packet of this information, clear instructions on this, what clear liquid diet means, what are things that you shouldn't drink, red, purple, blue. So it does give that clear explanation. And we do provide Docalax tablets in the office that can be picked up if you're not seen in the office prior. But again, if constipation is something that you deal with on a daily basis, you need to talk to the provider who is ordering the colonoscopy, because maybe something needs to be improved prior to the preparation of your colonoscopy to make that an easier process on you.
You said the NSAIDs and the vitamin C. Now, the NSAID, would that be what, like Tylenol, ibuprofen, and
NSAIDs,
vitamin C at all?
yeah. So NSAIDs are things like aspirin, ibuprofen, naproxen, Aleve, Advil, Tylenol is acetaminophen, so that doesn't have anything to do with the NSAIDs. The vitamin C, same thing. So even with the red meat, it's like 3 days prior to those fecal testing. That should be held. I know we have more questions.
You start laughing, so that you know what I'm gonna ask you.
It's okay, I like questions.
Cologuard versus just a regular colonoscopy.
So I tell my patients, the colonoscopy is gold standard. Okay, so you have a higher sensitivity rate. Again, there are missed polyps, but the missed polyps could be from the bowel preparation. So if you have a poor bowel prep, that's why you're coming back sooner. It depends on how bad the prep is. But if your prep is good and everything was been able to see, so as long as we're able to see all the way from the left side of your colon to the right side of your colon and no obstructive views, then it's gonna be almost 99%. I mean, there's always a type of polyps that are flat, that are hard to see because of the type they are, but majority of the time, it's gonna be a higher sensitivity. Again, I see the Cologuards, as long as we can get people through the colorectal cancer screening. But again, if it comes back positive, then we go on to the colonoscopy. A lot of times I find that patients are doing these and they have a history of colon polyps. They have a history of family colorectal cancer, you know, and really they should not be using this screening modality where colonoscopy should be the screening for them.
Why is it till age 75? I mean, I'm due for my next one when I'm 80, and I'm planning on being there.
So 75 is for colorectal cancer screening. So that tells me that you've made it to age 75 and you've had normal colonoscopies throughout that time. So they're saying at 75, I mean, the average lifespan for us, you know, if you're going to repeat again in 10 years, 85, and then if you're diagnosed with cancer, would you go through the treatment? So they're saying 75. That's saying that you've had normal previously. If you've had polyps previously, you're not ending at 75. You know, so I have patients in their 80s that are still getting these colonoscopies because of the polyp history, because of their family history of colon cancer. But again, that's also a discussion. That's not saying it's a hard stop. That is, you know, what is recommended. But I haven't had anyone jump for joy wanting one.
Well, but also the subjects are aware that they have a gene mutation
Yes.
that inhibits you from, you know, you can't survive
Yes.
a wild. And I'm one of those.
Yeah.
And I had cancer surgery 2 years ago, so I feel I'm definitely going for it. If I'm still alive at
Yeah.
I'm going.
Yeah. Like I said, so this is screening. You know, when we get into like your situation, that's more of, yes, it's screening, but it's more of a diagnostic. Yeah. Any other questions? I can see it in your faces, but you just don't want to ask.
You know, my last one.
Last one?
The Cologuard and the delivery drivers.
Oh. Yeah. So
What was the question?
The question was Cologuard, and delivery drivers.
as in like turning it in.
Right, and you have, there's another process, so you can do it, you do the Cologuard at home.
Yeah, you do the Cologuard at home, but you still have to take the box somewhere to be dropped off. And a lot of times patients don't want to do that because it seems like everyone knows what's in the box. Right? So-
Talking about, or if you call for like a delivery driver.
Yeah,
And you put that out, people
Yeah.
are like, oh, we know. So,
I have.
not to go against any type of screening, but they know.
Yeah. I have lots, I see lots of patients in the office, and, I feel like my job is, yes, I understand colonoscopy, having someone in your personal space is a big deal for people. But once they come in and they see me afterwards, they're like, that was a piece of cake. So the worst part is the prep, okay? But we could try to make that easier for you depending on what's going on. But, the staff, if you haven't been seen in the office, you'll see Dr. Raza, who prior to your procedure, outpatient setting, we also have anesthesiologist, Dr. Latour, who also sees you prior to your scope. And then we have all of our Rose endoscopy nurses who are great that we also work with side by side. So our entire team, nothing but good things to say about them. So don't be afraid. Come see me. Anything else?
Could I ask about your, was you do any comparisons to your accuracy or your methods or equipment or anything? Was Reid compared to other bigger clinics or like Mayo and all that?
So, comparison of,
As far as your accuracy?
okay, so like adenoma detection. I don't have, do we have those with us? Okay, I know, so we have a system that keeps track of adenoma detection. So we are within the gold standards of what an endoscopy suite should be. So we have a team that looks at that. We have a team that looks at, preparation is important, right? Because if we have a poor prep, we have an increased risk of missed polyps on the right side of your colon. We're able to pull up adenoma detection rate, so polyps. We're able to pull up, cancer findings. So all of these things is a gold standard within endoscopy, and that is what we follow.
Thank you.
And there is a team that that looks over all of that as well to make sure that we are keeping up with the gold standards.
Is he the only doctor that does colonoscopies at Reid?
So we are Reid Health Gastroenterology, so we've been in office since 2019. So Dr. Raza is the only physician in our office. There's also a private physician that uses the Reid's facility that also does colonoscopies within the community. But he is not within our office, and I think that has a lot of confusion for people too. Yeah.
To help our colon, should we eat more fiber or just healthy foods or?
To help your colon, as in with the preparation?
Well, no, you were saying, stay away from short foods and stuff. I was just wondering what kind of,
Yeah.
do we need
So
more fiber?
do we need more fiber? I would say yes. I mean, it is recommended that we have 25 to 35 grams of fiber a day. And if you really looked at nutritional labels and to see what you're intaking versus what we should be having, you'll be surprised that you're probably not even getting half of the recommended dose. Fiber helps keep our bowels regulated. So fiber is very important for us. But that's not going to play any role in regards to your risk factors. That's going to help with more of just keeping your bowels regular and help with the preparation too. Any other questions? Nope. Okay. I want to thank everyone for allowing me to come in and discuss this with you today. Appreciate it.
I want to thank everyone for joining us this month, and we'll see you next month, same place.